So good evening, friends. I'm Philip Finney. I'm one of the senior consultants in endocrinology at the Believers Church Medical College Hospital. It's my privilege to host this webinar, which is the 74th international webinar we've been doing during this lockdown and post-COVID periods to keep us all abreast of the latest advances in medicine. And it's my privilege today to introduce two gentlemen who are joining us to lead us in this discussion. We have our guest speaker today is Dr. Bhavin Dalal, and I went through his CV. It's a fairly long and impressive CV, but I will just try to make it short in view of time constraints. And Dr. Dalal has had his undergraduate training in Ahmedabad, and thereafter did his postgraduate training as well in internal medicine. And in 2002 has moved on to the States and did his training and residency in internal medicine at the Temple University Hospital in Philadelphia. Went on to Michigan and in the Wayne State University did his training in pulmonary and critical care medicine, and also did an interventional pulmonology training at the Cleveland Clinic in Ohio. And it's been a very impressive academic record Dr. Bhavin Dalal has had, and it's such a privilege for us to have him speak to us on updates in sleep medicine. I'm just now struggling with an endocrine patient of mine with a morbid obesity of 240 kilos who's having severe OSA, and he's in the ward right now. And I see him struggling for sleep and problems. But I know that OSA is just one of the issues which we face in sleep medicine. And I'm going to also introduce the moderator for today is Professor Bala Mugesh, who's the head of pulmonary and critical care medicine till recently of the CMC Vellore. And it's my privilege to have Bala Mugesh to moderate this session. And I'm going to hand over the session to Bala Mugesh to say a few introductory remarks and then give the session over to Dr. Dalal for the talk. Thank you very much for accepting our invitations, Dr. Bala Mugesh and Dr. Dalal.
Thank you, Dr. Philip Finney, for this wonderful opportunity to join in this webinar. When you ask a person what are the most important necessary requirements for a life, they will say, okay, you need food, you need water, you need shelter. And nowadays people started realizing the importance of air, even oxygen we breathe. It is very important for life. Of all these things, many people forget that sleep is a very important ingredient, necessary requirement for a good life. An average human being spends 1/3 of his life either sleeping or preparing to sleep. And without a good night's sleep, your life is not going to be fruitful. I was reminded of a verse in the Holy Scriptures, which is given in the book of Proverbs. When you lie down, you will not be afraid. When you lie down, your sleep will be sweet. Your sleep will be sweet. A sweet night sleep is one of the greatest blessings we as human beings can have in our life. And I'm glad that this webinar has been organized and we are having an eminent speaker, an expert to give us lights on the recent advancements in the sleep medicine. Over to Dr. Dalal.
Good evening, everyone. Thank you, Dr. Jacob, Dr. Feeney, and Dr. Bala Mukesh for the kind words for the introduction. I absolutely concur Dr. Bala Mukesh words that sleep is very important and unfortunately most commonly ignored. We are always thriving for the food and water, but the sleep is always compromised when we have to do something, including study or partying or anything. And the 7 to 8 hours of the good quality sleep is necessary. So in this short an hour of a lecture, we will try to touch base with some common sleep disorders. Can I share my screen? I think it looks like okay. Can you guys see my screen? I'm not able to see myself, or the browser window is behind this particular screen. So can you guys hear me and can you see my slides? Okay, looks like everyone can see and hear me. So uh, I don't have any financial disclosure for this particular talk. As Dr. Feeney mentioned that he's struggling with a 240 kilo weight person in his ward, and definitely we are moving towards this trajectory, unfortunately, and we need to do some better job to control the weight in general, which is a message. But let's talk about some sleep part. So in this short lecture, we will try to review some common sleep disorders, order appropriate sleep study, refer the patient to the sleep specialist if necessary appropriately, and finally follow up with the patient with the sleep disorders. So as I told you, there are lots of sleep disorders, but the two common ones we will touch base today will be sleep apnea, which is the most common, and the insomnia. There are several other interesting sleep disorders like narcolepsy and REM behavior disorder, but we will try to talk about those some other time. So before we kind of go on to this, the webinar, I wanted to make it more interactive. So I have a question for you guys. The 55-year-old man underwent for a polysomnography or PSG for evaluation of snoring and sleepiness. His AHI, apnea hypopnea index on the polysomnogram was 35 per hour. What is the severity of his sleep apnea? Mild sleep apnea, moderate sleep apnea, or very severe, severe sleep apnea. So if you guys are on a browser or on a phone, can you please join on this particular app, vevox.app, vevox.app, and it will ask you to place an ID number, which is 151787064. So I've started the poll. Again, if you guys can join on a browser or on a cell phone, if you have an app, or on a cell phone browser, doesn't matter. It will work from all different platforms. vevox.app, vevox, and then try to enter this ID number 151787064. I'll give you a couple of 30 seconds to a minute so people can log in on a different browser. Okay, I'm going to stop the poll. Okay, so majority of the people are saying severe sleep apnea. Let me touch base with some of the basics of the sleep apnea. Apnea meaning by cessation of airflow. So if I draw the graph of the airflow, the cessation of seconds or longer will be defined as apnea. As we know, there are two types of the apnea. One is a central and the one is an obstructive. One second, I think can you guys see my slides? Okay, oh wow, it all came up in the. So the one is a central and the one is an obstructive. Ultimately are defined as the same definition, that flow for 10 or longer seconds. How do we differentiate central from obstructive? We need to look at either a thoracic or a diaphragmatic or abdominal movement. As we can imagine, the central apnea comes from a center, meaning by respiratory center. When the respiratory center is not sending a signal, there will not be any movement of a thorax or abdomen either. So along with the cessation of airflow, there will be a cessation of respiratory movements. While in case of obstructive apnea, the abdominal or the thoracic movement will still be continued. So if we do see the movement of the abdominal muscles or thoracic muscles along with the cessation of airflow, we will label them as an obstructive apnea. In both the cases, most likely the oxygen saturation will go down because the person is not breathing, and depending on the how long the person is not breathing, the chances of the more and more oxygen desaturation can happen. On the other side, hypopnea is approximately 30% or higher decrement in the flow compared to the normal flow. As you can see in the first graph, most of the time we do not differentiate hypopnea into the obstructive and central categories, but this is an example of possibly obstructive hypopnea in which you can see the effort of the thoracic movement or the rib cage and the abdominal muscles is still going on. The efforts in the pleural cavity is still going on, and the saturation is going down by approximately 3% or 4%. AASM, which is American Association of Sleep Medicine, possibly the largest reputed organization, has two definitions of the hypopnea. One says that the hypopnea is 30% or more decrement in airflow with arousal if you have EEG attached to the patient in case of a polysomnogram. So you can see in the EEG there is a arousal. So if the person is aroused from the sleep, will be considered hypopnea. Or if the person has a 4% decrement from a baseline oxygen saturation. So if the oxygen saturation was 95, 95, 95, and along with this decrement of effort, if the saturation is like 91%, we will label or we will define that as an hypopnea. So what we do, we technically count all the events which are either apneas or hypopneas throughout the night and divide them by the hours of a sleep. That will give us a number, the AHI or apnea hypopnea index meaning by events happening in an hour. If AHI is below 5, that means it's normal. If the AHI is between 5 to 14.9, it is mild sleep apnea. Between 15 and 29.9 is moderate sleep apnea, and more than equal to 30 is severe sleep apnea. So our patient had a AHI or apnea hypopnea index of 35. That means the patient has a severe sleep apnea. Why the sleep apnea happens? The principal factor is basically anatomical narrowing, and because of the obesity or overweight, there is a significant narrowing of the upper airway because of a more and more fat in the retropharyngeal area. There are several other mechanisms why it happens in a sleep. For example, because there is a more collapsibility of a muscle, the ventilatory instability is also present, but the most important part is a narrowing. And this small video make you understand even more what exactly is happening while we sleep. We breathe. So that brings us to the next question. Which one of the following factor is associated with a reduced risk of obstructive sleep apnea? Meaning by all the factors are actually associated with increased risk factor for the obstructive sleep apnea, but the one is actually reduced risk of a sleep apnea: male, age, neck circumference, BMI, and hormone replacement therapy. So I will open up the poll. Again, the people who are joining now, if you go on a browser and open up the or go to this address, vvox.app, vevox.app, it will ask you to put an ID. ID is 151787064. We are looking for the risk factor, which is technically not a risk factor, or it is a protective against the OSA. So I'm going to close the poll. Again, I think that you guys are pretty smart. And then the people are saying hormone replacement therapy is not a risk factor. Everything else is a risk factor, and that's probably the correct answer. The hormone replacement therapy is only important for the women, although so let's look at a one by one factor. Age certainly is a very strong factor, and as we grow, as we get old and older, chances of having sleep apnea increases, as well as the chances of having severe sleep apnea is also increasing. So the age is certainly a factor. You can see that the after the age of 50 or so, suddenly there is a jump in the prevalence or the incident rate of the sleep apnea. Weight and OSA, as Dr. Finney was mentioning, he's struggling with a guy who has a 240 kilo weight. Absolutely no question. We have all recognized that the weight is certainly an important factor, and the relationship is bilateral, meaning by more the weight, there are chances of a more uh, chances of having sleep apnea or more severe sleep apnea. Vice versa, if person lose weight, the sleep apnea is likely to regress. And this is a common thumb or the equation that the 10% body weight is approximately correlated with 30% of the AHI. This is very interesting and important for a prevalence of the OSA in women. Women, as soon as they become postmenopausal, the odds ratio is suddenly like 1.9 or approximately 2. So that's almost twice, the 1.9 OSA instead of the 0.6 when they are postmenopausal. But when the postmenopausal women are treated with a hormone replacement therapy, the prevalence rate goes down like a normal population or the premenopausal women. And a postmenopausal women without hormone replacement therapy down the road has even more increased prevalence of the sleep apnea. So we can tell that the postmenopausal treatment, women who are treated with HRT probably has a less prevalence, although we don't treat by this way the sleep apnea, just it's a prevalence. Which one of the, now, why should we know about the OSA, or why should we worry about OSA? As I was showing in that video, the one part was clear that whenever the person has apnea or hypopnea, probably there is a micro arousal and the brain is not getting sound or the good sleep. People don't even go to the N3 or the REM sleep. and next day they feel tired, next day they feel fatigued. But apart from feeling fatigue or tired, are there any other problems? And of course, there are a lot of problems associated with sleep apnea. So far, the evidence is, and which I'm going to show in the next few slides, we do have a quite bit robust evidence of a different bodily problems or physical problems along with the sleep apnea. But one of this thing is not yet been defined to have association with sleep apnea: hypertension, stroke, minoca, cancer, and CHN. So I'll open up the poll, and people can still respond the same way, the vvox.app, and you can enter this ID 151787064, those who are joining now. And the question is, which one of the following is not associated with OSA? And this is purely, it may be down the road, but so far we do not have an evidence. Okay, I think the correct answer here is minoca. So far, we do have actually evidence that the cancer is also associated. I have several patients, and there are several, the research cohort study research which do show different types of cancer. One of the common cancers are actually skin cancers or melanoma associated with OSA. There was a paper in a chest. Probably in 2008, 2009, around 250 patients had a strong association after neutralizing every other risk factor for melanoma and severe sleep apnea. So cancers are probably associated with sleep apnea. But so far, we do not have evidence, and I guess probably it is, and I'm emphasizing the word so far because this is a pretty new term we have coined, minoca, MI with a non-obstructed coronary arteries. I'm pretty sure that somebody will find an evidence or the association along with the sleep apnea down the road, and that's why I'm saying that so far the word is very important. Almost every single heart or the stroke or the kidney disease have an association with a sleep apnea. Whenever we say in the world of medicine the association, we may not say it is a causative factor, although there are several genetic and the cellular level mechanisms people have found out which may help us to define that this may be even a causative factor, but that's beyond the consideration of our clinical practice. So as you can see that the association between the patient of OSA and hypertension, for example, 30 to 85%. Ischemic heart disease, again, half of the people. Stroke has a strongest association with almost 45 to 91% of the patients. Heart failure with reduced ejection fraction, preserved ejection fraction, hypertrophic cardiomyopathy, Afib, and renal disease. So quite a bit strong association with the common problems we do encounter in a day-to-day life and the OSA. I always say that the OSA is a heart disease and to be treated like a risk factor for the heart disease rather than just sake of the sleepiness or tiredness. What can be the mechanism? There are so many mechanisms. For example, decreased peripheral nervous system activity or arousal is leading to the increased sympathetic nervous system activities and catecholamines. Myocardial oxygen delivery has gone down, oxidative stress, intrathoracic pressure changes, and then the LV wall tension is changing. Out of all this mechanism, I will say that the increased sympathetic nervous system activity and increased catecholamines are probably the most important. Again, there is not a quantitative one versus another, but the reason why I'm saying this one is a more important, as we can imagine, when the person is actually sleeping normally, the respiratory flow is normal, the blood pressure is normal, heart rate is normal. In a patient who has obstructive sleep apnea, when the flow is not there, blood pressure will fluctuate, which is an indirect consideration of a sympathetic nervous system activity changes forth and back. Now, we originally thought that this kind of the change in the sympathetic nervous system activity or the increase SNA tone will be prevalent only during the time of the apneas or hypopneas, meaning by this will only be prevalent at the time of a sleep. Unfortunately, when those patients, you can see in a bottom cartoon diagram, unfortunately, when those patients were studied during a daytime, like when there is no apnea, they are breathing normally, still they have a significantly sympathetic nervous system tone was significantly heightened. And that means they have a nightly SNA activities increase, the daytime activities increase, and that is persistently causing the sympathetic nervous system torture on a body, including the heart, lung, and the brain, and those are the ones responsible for this end organ damage. So a very interesting phenomenon by the Gary Somers from Canada, coined almost 22 years ago. So that is the one which is responsible factor for driving all this heart and the brain problems. I think all of us has recognized that the hypertension is a very good buddy or a friend with the sleep apnea. In this study, which was published, almost 2 decades ago, showing a quite a bit association here. For example, on the left side, you have a AHI 0.1 to 4.9, meaning by this normal, and a baseline blood pressure, the blood pressure after adjustment for the age and gender, blood pressure after adjustment for the body habitus, weight and neck circumference, and the blood pressure after adjustment for the alcohol and the smoking. When it is increased from 5 to 15, meaning by mild sleep apnea, the odds ratio has gone up almost to double. When it is increased more than 15, the odds ratio has gone up again almost to 4 times. So then we can say that the higher the AHI, meaning by more severe the sleep apnea, there are chances that the people will have a more and more likelihood of having hypertension. It has been said and studied that when the people do have refractory hypertension or difficult to control hypertension, and the definition for that is if they require 3 or more medications from a different group to control high blood pressure, just that one line, you will find 85% of those people do have a high blood pressure. So if the person has a refractory or difficult to control hypertension in your clinical practice, certainly should be screened for a sleep apnea, because you are going to find out 85% of prevalence. CAD and a mechanistic studies, as I said, that the vascular level or the cellular level studies we have to understand the cause-effect relationship between the sleep apnea and coronary artery disease. We have studies to demonstrate that the sleep apnea and ST segment changes suggestive of CAD. Even angiographically proven coronary artery disease, we have evidence that the prevalence is quite higher when the AHI is more than 10 compared to normal population. The stroke, as I mentioned, has a strongest relationship, and the most important part in this particular slide is the references. There are studies after studies after studies in a different cohort has been shown that the sleep apnea and the stroke has a great association. For example, in this particular study, this is the latest from the Campos. After the adjusting for everything else, the hazard ratio was almost 6.4, meaning by the patients who have a sleep apnea are almost 6 times more likely to develop the stroke compared to the normal population. And very impressive, and we do see this clinically in the ICU and the floors again and again, that the lot of stroke patients do have a significant sleep apnea, and retrospectively we should screen them also. Arrhythmias are again, as I mentioned in the previous table, almost more than half of the population has a sleep apnea. While we do read the sleep studies, we do see this phenomenon so commonly that every time during the EKG, I will see a different types of arrhythmias. The question here is, which one of the following arrhythmias are most likely to occur in association with OSA out of this 4? Afib, Vfib, atrial tachycardia, sustained ventricular tachycardia, or VTAC. So I'll open up the poll. Again, those who are joining now can go onto this app, vvox.app, and add this ID 151-7874. The question is, which one of the following arrhythmias is most likely in association with OSA? Okay, I think the correct answer is the Afib. The Afib and we do get almost 35% of our patient population for sleep studies and the sleep evaluation from our EP, the electrophysiology cardiologist, again and again. Afib and the sleep apnea are the best friends. In several studies, the Afib prevalence was pretty high. On this study, you can see that the complex ventricular ectopy was having the highest prevalence, but I did not give you that as an option. Compared to the sustained VTAC or the Afib and VFib, the Afib is the most common. Almost 48 to 52%, so almost half of the patients, with sleep apnea do have arrhythmias. Almost half of the patients do have a Afib, or little less than a half. Good thing is that when we do treat the sleep apnea with CPAP or a BiPAP therapy, the arrhythmia prevalence has significantly gone down. What about the sleep apnea and a heart failure? There is an interesting mechanism, as you can imagine, that the sleep apnea happens, or obstructive sleep apnea happens, due to an obstruction in the upper airway. So the upper airway is obstructed, person is trying to take a negative breath, so it will generate a negative intrathoracic pressure, and which will cause a shift of the fluid, the venous return, significantly towards the thorax, and the patient will have a more pulmonary edema. So on one side, the sleep apnea does increase the CHF, and once you have a more CHF, you may have a more upper airway obstruction due to the fluid. So that is causing more sleep apnea. So it's a kind of dual fold problem that the sleep apnea does increase the pulmonary edema or CHF, and CHF does increase the sleep apnea. So very interesting mechanism, and probably can be reduced by the CPAP therapy. This is a very interesting mortality data from New England Journal of Medicine. The people who have a no sleep apnea or a mild sleep apnea in case of ischemic cardiomyopathy, compared to the patient who did have a sleep apnea, had a significant less survival overall. The same data were not showing a same difference for a non-ischemic cardiomyopathy, but at least for ischemic cardiomyopathy, there is a strong relationship with a mortality and the presence of a sleep apnea. Similarly, even all-cause mortality. These are the two largest database in US as well as probably the worldwide. Wisconsin sleep cohort, and you can see that the patients who have a no sleep apnea, mild sleep apnea, moderate sleep apnea, and severe sleep apnea, the survival is going down and down, and especially for a moderate or a severe sleep apnea, there is a significant less survival over 15 to 20 years of follow-up. So the longitudinal data do support the mortality and the sleep apnea. Same way, the sleep health heart study also does show the similar situation between no sleep apnea, mild sleep apnea, moderate sleep apnea, and severe sleep apnea. The survival goes down. So the question again, that the 65-year-old man, history of hypertension, BMI 37, neck circumference is 18 inch, history of recent STEMI, ST elevation MI, EF is 40%, was sent by his cardiologist for a sleep study. He has no history of snoring and no history of daytime sleepiness. What will be the next best action? Perform a home sleep study, perform in-lab polysomnography, start him on an auto CPAP without sleep study. Sleep study is not indicated without history of snoring and sleepiness. So again, you probably are getting similar type of patients in your clinical practice, and very important, what kind of a study should we order or we shouldn't order the study. So here I'm going to open the poll. Okay, so again, all of you guys are saying the perform the in-lab polysomnogram, which is the correct answer. When we screen the people in general, we do use this thing for all our sleep patients, known as a stop bang algorithm or the stop bang scoring system. S for the snoring, T for the tiredness, O for the observed apnea, P for the pressure or systemic hypertension, B for the BMI more than 35, age more than 50. I showed you in the previous graph why the age of 50 was taken here as a criteria. Neck circumference of more than 16 inch and 40 centimeter, and the G for the gender. The male gender is more likely to develop sleep apnea. So if the somebody has a more than or equal to 3 risk factor, chances of them having sleep apnea is around 65 to 75%. So this is a very easy screening tool for the patients to screen. I will say that for Indian population, some of this number, for example, BMI more than 35, may need to be changed, because in the Indian population here in United States, we have seen sleep apnea even with a lesser degree of a weight, probably due to our craniopharyngeal abnormalities. So we do have as an Indian ethnicity population, we do have a high prevalence, but unfortunately much ignored compared to the last recent years. So in our patient, yes, had quite a bit of a risk factor. And what type of a test should we order? Even though he did not have a history of snoring, he has a like 1, 2, 3, 4, 5, 6 of a score. So he will need some form of the sleep study testing. So we do two different types of sleep studies. The one happens in a lab known as a polysomnogram or PSG, and the one happens at home known as a home sleep apnea test or HSAT. In a home sleep apnea testing, you can see there is a little belt. There is a the flow sensor at the nose, which is kind of measuring the flow and the temperature. The belt is measuring the patient position and also the abdominal and thoracic muscles movements, because I want to differentiate central apnea from sleep apnea. There is also a pulse ox at the level of a finger. So the flow, the effort, and then the pulse, these are the three mandatory channels. Different home sleep apnea devices have a different kind of a monitoring capacities, but these three are the most important and the mandatory according to the American Academy of Sleep Medicine. While home sleep apnea study should be reserved for a specific population. So what are the indications? The people who have a high pretest probability of moderate or severe sleep apnea. In lab PSG is not possible. For example, somebody is completely immobile or somebody has a critical illness, and monitor the response to the non-CPAP treatment of the sleep apnea. Sometime we do this one. But the contraindications are important to remember rather than the indications. The people who have a significant comorbid medical conditions, for example, heart failure with reduced ejection fraction. Our patient had a heart failure with an EF of 40%, so that falls under that category and should not subject for the home sleep apnea testing. Advanced cardiopulmonary disorder, including interstitial lung disease or COPD, the people who are on a home O2, people who have a recent stroke with disability or the limitations, those patients should not be subjected for the home sleep apnea study. If we are thinking of other sleep disorders, for example, periodic limb movement disorder or the RLS or the narcolepsy, those patients should not be subjected for the home sleep apnea study. So our patient will probably do require polysomnography in lab. And why the polysomnography is known as polysomnography? Because we have a lot of grams. For example, electroencephalogram. So in a first 1, 2, 3, 4 channels, the first 4 line, you can see the electroencephalogram. So I want to actually know whether the patient is sleeping or not. And if the patient is sleeping, what type of a sleep he is getting. N1, N2, N3. And if I want to know the REM sleep, the rapid eyeball movement sleep, I should have a sensor on the eye muscle or the lid muscle. And as you can see that the eyes are going to move in a different direction, like by the electrode polling. And so this is known as an electrooculogram. So you have electroencephalogram, electrooculogram. We also measure the chin tone. We have an electrocardiogram, our conventional EKG or the ECG. There is a snoring channel, so we can hear the snoring and we can record the snoring. This is the flow of the nose. And this is a thoracic and abdominal muscle G or electromyogram. There is SpO2 or the SpO2 or the saturation and the heart rate. So these are the kind of almost 14 different channels in the polysomnogram. That's why it is like there are a lot of grams. That's why it is known as a polysomnogram. So once we have the polysomnogram, we can actually figure out according to the AHI whether the person has a sleep apnea or not, and if the person does have a sleep apnea, what can we do? What is the treatment? I think again you guys are probably familiar, but whenever we do treat, we always want to ask a question that what I'm changing. Am I changing just the symptom? Am I changing the mortality? Am I changing the risk for the myocardial infarction? And that question needs to be asked with every single type of a treatment in the world of medicine. So for example, here the question is, PAP therapy in patient with obstructive sleep apnea has shown to improve all of the following parameters except systolic and diastolic function, arrhythmias, sleepiness, mortality. I'll open up the poll. Okay. So I think the correct answer here actually is a mortality. We do have evidence that the systolic and diastolic dysfunction actually gets better with the PAP therapy, and I will show you the evidence. So far in a randomized controlled trials, we have failed to demonstrate a mortality, and I will talk about that in a few slides because there is a problem with the study data. But so far that evidence is not there. Everything else, we do have an evidence that it does change with the PAP therapy. So these are the things that we have seen by the CPAP, for example, on the neurocognitive function, that of course it improves the neurocognitive function, improves the sleep quality, improves the stages 3 and 4. This was an old study, so they are still saying stage 3 and 4. Now we only have a 3 stages, N1, N2, and N3, and not N4. Sleep efficiency, daytime sleepiness, these are the definitely has shown again and again in the prospective studies. Similarly, driving simulator performance has been shown to improve. So we have quite a robust evidence that the several neurocognitive parameters, including sleepiness, does get better. Effect on the heart, so the systemic hypertension gets better, the LV systolic and diastolic function gets better, pulmonary hypertension gets better by the CPAP therapy. The Afib is we have an awesome evidence for the Afib. The ones we have treated, for example, here you can see that the Afib recurrence rate, even after they have been treated with a cardioversion or they had been treated with the pulmonary vein embolization, no sleep apnea, treated sleep apnea, all sleep apnea, and untreated sleep apnea. So the untreated sleep apnea, almost 80% chance that within next 2 years they will have a recurrence of the AFib with RVR. But they are treated with the CPAP, that number goes to like 40%, meaning by we are able to reduce the recurrence rate of the AFib after the cardioversion by almost 50% if we have treated the patients with the PAP therapy. So very interesting data for the AFib and the PAP therapy. Again, the randomized controlled trials also have shown all types of arrhythmias go down by 50%, which kind of makes sense. As far as the mortality is considered, this is probably one of the largest randomized controlled trial, and I'm proud to say that actually several centers were in India when this study was published in New England Journal of Medicine in 2016, known as a SAVE trial. So you can see that there are approximately 3,000 patients who had a moderate to severe sleep apnea with history of CAD or CVA. They were randomized to receive either a CPAP therapy or a usual care, meaning by no CPAP. And the the p-value was not significant for a mortality at almost 84 months, which is a pretty long follow-up of almost 7 years. So a pretty robust study, um, and did not show the difference in a mortality in a randomized controlled trial, and did not show the difference in MI, stroke, hospitalization also. But one of the biggest problem and criticism about this study was that the mean CPAP usage was 3.3 hours. The minimum required for the treating the sleepiness in the United States, we are very you know anal about this compliance, and the compliance is considered the more than 70%, meaning by the person has to use it for more than 4 hours for more than 70% of the time in a month. So out of a 30 days of a data, we need a 22 days the patient did use it for more than 4 hours. So everybody is actually scratching the hair that how come that happened, and how come this was published in the New England Journal of Medicine. This is a straightforward consideration. If someone is getting a treatment for hypertension, you give them amlodipine. A person is not taking amlodipine, his blood pressure is not going to be controlled. So this was a very important part, that the mean usage in the people who were in a CPAP arm, they use it for only 3 hours a night. How it is going to give a benefit out of a 7 hours of a sleep, because rest of the 4 hours or 4.5 hours, the sleep apnea was not controlled. And we have a similar studies actually with a similar type of a problem. One is known as a circus, the SAVE I showed you, which is the largest trial, and then the records. These are the 3 studies published in last 10 years and did not show a difference in the mortality. But Dr. Jawahari from Hopkins did a phenomenal analysis, and what he did out of these 3 studies, which are all randomized controlled trial, he took the patient who had used CPAP for more than 4 hours. So for example, now you can see that there is a p-value which is significant. Now even in a SAVE trial, he only took the patient who used the CPAP for 4 hours or longer and excluded the rest of the patient. You can see that they did have a survival benefit. And similarly in this trial also, as soon as we took the patients who had used the CPAP only for more than 4 hours. Those people do have actually survival benefit, but I cannot extrapolate a statement for a generalized population because we still don't have a exact type of a data, and that's why that answer was relatively, in a concern. But there are still more studies are going on, and people are hoping that the CPAP therapy will show the difference in survival. When I do see the sleep patient, this is what do I see. For example, here you can see more than 4 hours and 30 days downloaded data. So the patient has 100% compliance for more than 4 hours, and the patient has a residual AHI of 0.4. So this patient had an excellent control of a sleep apnea and excellent compliance of sleep apnea. These are the patients probably will get a benefit. In general, unfortunate situation that the people don't like to sleep with, the something on the mouth, on the face, and the compliance is going down over long term. Long-term compliance in the United States is about 29 to 83%. So I expect that the half of the people, they don't actually use the CPAP machine over time. In the next, I think, few minutes, I will try to cover insomnia. A lot of people thought that the insomnia is not that common, and how do we define the incident rate matters. It has been said that the 1 in 3 person on earth will develop insomnia for the short time or a long time over their lifespan, at least one. So insomnia, if we define the insomnia by that way, or the incident rate, if you look at that way, actually the incident rate is higher than the sleep apnea. So that's why I just mentioned here, it's probably a commonest or the most common sleep disorder. So I have a question that Mr. Maximus is a 55-year-old guy. He is an office worker. He has a stress due to the possibility of losing his job after the COVID. He drinks 2 glasses of wine at night, smokes a pack of cigarettes. His schedule is job time is from 8 to 4, runs on a treadmill around 9 p.m., trying to sleep. So he's a good guy. He's doing the healthy things, at least partly. Trying to sleep around 10:30 to 11 p.m. on the phone for 45 to 60 minutes. Sounds familiar, right? I think all of us unfortunately do this thing nowadays. Sleeping around 12 midnight, sleep latency is 30 to 60 minutes. Sleep latency meaning by when the lights are closed or when the eyes are closed. Approximately how much time does it take to fall asleep? So starting from the eyes closed to the actual sleep, that is known as a sleep latency. 4 of the 7 nights he wakes up around 4:30 a.m. and then he cannot go back to sleep. Final wake time is around 6 a.m. and the job time is 8 to 4. So the routine schedule, every time again, we do take the history and document this thing in the chart again and again. This is my typical patient history because I have all these parameters listed in the every single sleep patient I do see. He feels exhausted during day. So what will be the next best step of action to improve the middle of night awakening? As I mentioned that the guy does wake up at 4:30, almost 4 out of 7 nights, and then he cannot go back to sleep. So what can we do? Change the sleeping time to 9 p.m. and wake up at 4 a.m. instead of the 10, like instead of 11:30 to 6. Can we prepone the sleeping time, because anyway he wakes up at 4, so let him wake up at 4 as a routine. Stop smoking, stop drinking alcohol, and stop exercise or treadmill. So I will open up the poll. What will be the correct answer or the correct action for improving his nighttime awakenings? Okay. Stop smoking. Okay. So remember the insomnia, there are two types, or we always say the insomnia meaning by inability to sleep. Now, inability to sleep has to be differentiated in two categories. Inability to initiate the sleep, which is known as a sleep onset insomnia. So the person is not able to sleep in a first half. And the second part is a person is not able to maintain the sleep, which is known as a sleep maintenance insomnia. So the insomnia, whenever you encounter, or they can have a both. They have a sleep onset and sleep maintenance insomnia. This gentleman looks like have a both problem, that he is on a phone for almost an hour and then another hour he takes to sleep. So he has a sleep onset insomnia, but then he wakes up at 4:30 and then he cannot go back to sleep. So that means he has a sleep maintenance insomnia also. So the question here is that what action will improve the middle of night awakenings, meaning by what action will improve the sleep maintenance insomnia? The correct answer for that is actually stop drinking alcohol. Stop smoking will help the sleep initiation onset or the sleep onset insomnia, but may or may not have a much of impact. But the drinking alcohol has a significant impact, and I will show you. Alcohol unequivocally has been shown to reduce the sleep quality, and it is dependent on the amount of the alcohol people consume. For example, low alcohol, which is less, 2 for men, 1 for women, 9.3% decrease in a sleep quality, moderate 24% decrease, and then the high amount of alcohol, almost 40% decrease in a sleep quality. Alcohol also reduces the REM sleep. So for the first 2 cycles, what happens, remember the normal physiology, we go from N1 to N2 to N3 sleep, which is around 80 to 90 minutes. And then we will have a 20 minutes of the REM sleep. Then again, we will go for a non-REM sleep, the N2, N3, probably for another 100 minutes. And now, or the 90 minute or 70 minute. And then now we have a 30, 35 minutes of a second REM episode. So the alcohol does suppress the REM sleep, and when that REM sleep is suppressed, say for example at 3 or 4 o'clock, person will wake up suddenly and then they cannot go back to the sleep. Alcohol also actually increases the sleep apnea by the virtue of relaxing the muscle. As I was showing in that video, that the muscles, they collapse more, and if they collapse more, they will have a more sleep apnea. So alcohol has a quite a bit of a detrimental effects on the sleep, and a routine alcohol use needs to be prevented. It's a very important part. Let's talk about the other answer. So, for example, changing the sleeping time, it is not practical and not possible that the person will wake up at 4 a.m., but he has to go to the job at 8. What is going to do from 4 to 8, right? So that's not practical. Stop smoking, as somebody mentioned, and I think that's very important, which will improve the sleep onset insomnia. Remember, the nicotine is a very stimulant substance, and the significant impact on a sleep onset insomnia. Stop alcohol, as I mentioned, and stop exercise. So American Academy of Sleep Medicine mentions that the people should not do vigorous exercise approximately 2 to 3 hours prior to the bedtime, because when we do exercise, we do generate catecholamines, and those catecholamines will keep the person awake. So stop treadmill will help the sleep onset insomnia, but may not have impact on a sleep maintenance insomnia. So that's why the rest of the answers were probably partially not correct. So the Mr. Maximus is actually a pretty good guy, and he stops drinking the wine. He stops smoking at least after the evening time. He changes time of exercise to 5 p.m. instead of 9 p.m. So nightly awakenings are improved, but the sleep onset insomnia is still a problem. Apart from improving the sleep hygiene, what will be the next best intervention? Consider trazodone, consider melatonin, consider stimulus control therapy, consider app-based noise therapy. So now we are talking more about a treatment for a sleep onset insomnia. Should we treat with medications or do something else? So consider stimulus control therapy is the correct answer. The American Academy of Sleep Medicine, by the way, is not recommending actually any medication to be considered for a long term. And then the long term is kind of a word abused by a lot of practitioners worldwide. But American Academy of Sleep Medicine certainly has in a 2017 guideline mentioned that do not use trazodone or melatonin for the purpose of sleep inducing considerations. So these are the definitely wrong answers. Consider a sleep stimulus control therapy, and I will talk about that. But this is a situation data from the USA. The 88% of the people actually watch TV or some kind of a streaming consideration. 66% of the population read a book. 60% of the men or the people watch sports, and half of the population is playing video games in the bed. And these are the all bad habits. Unfortunate situation. We have a textbook statement says that the bed and the bedroom is only for sleep and sex. None of these activities should be done in the bedroom. In another analysis, unfortunate situation, the United States is losing $411 billion. This is not a million, this is $1 billion every year because people are not sleeping. I'm not sure what are the data for the India, but you can see the Japan, Germany, all the developed countries, people do not sleep. And as Dr. Balamukesh was saying, that the sleep is very important, and here we have a data that the people don't sleep and how much does it cost. So I think that consider a sleep stimulus control therapy is the most important answer. And what is that? So what we need to tell the people that when you are in the bed, for example, lights are off at your designated sleep time, there should not be any noise, there should not be any light, room is dark and room is cold, you are trying to sleep. If you are not able to sleep for 15 to 20 minutes, and that 15 to 20 minutes is or 30 minutes is a random guess. You don't have to see the clock, because watching clock or seeing clock or the watch is creating anxiety of not sleeping. People think, oh wow, it's 2 a.m. in the morning, I'm still not able to sleep, I have to go to work tomorrow. And that anxiety will not let you sleep. So then that will cause a more insomnia. In the literature, it is known as a perpetuating factor, meaning by you are eating your own tail. So anxiety about insomnia will create insomnia, and that's the biggest problem. So person who is in a bed for 15, 20, 30 minutes maximum, randomly, not looking at the clock, if they're not able to sleep, don't lie down in a bed and toss and turn. Go out of a bedroom, go to the living room, go to the kitchen, do something what you do not like, where your mind is not attached. For example, playing sudoku on paper or reading history book or something will immediately make you to sleep or something like that. So everybody is different, and we have to find out a different solution for the patients, that whatever they do not like. Our medical students, I'm pretty sure, are joining on a call, try to read a biochemistry, and then they will be immediately able to fall asleep. And so something you don't like, and then those activities should be done. As soon as they feel a little drowsy, a little sleepy, run back from the from a living room to the bedroom and try to sleep. If you wake up in the middle of night, and the same principle applies, you drink a little water, go to the bathroom, come back to the bed. Even next 15, 20 minutes, if you're able to sleep, you are out of the bedroom, go to the living room, do the same kind of activities. This is known as a stimulus control therapy, which is a part of cognitive behavioral therapy, and that is shown to improve the uh, insomnia. This is a little algorithm. How should we treat insomnia? So non-pharmacological and pharmacological. Non-pharmacological, as I mentioned, has been recommended only for a short period of time. So maybe a week or 2 weeks or 4 weeks of a therapy. Again, that short and long is not defined clearly, so people are abusing for months and years. But normally, when we give a short-term pharmacological therapy, for example, is for the patient who lost a job, so for next 2 weeks, or somebody died, or somebody is in a hospital for a pain or operation. Those are the times we consider the pharmacological therapy. Non-pharmacological therapy is education, like what I told you, in the CBT, or a cognitive behavioral therapy. Education is a sleep hygiene. Sleep hygiene meaning by you go to the bed at the same time, wake up at the same time. Stimulus control therapy and sleep restriction, or a bedtime restriction. CBTI in person, or CBTI on internet. So there are a lot of internet-based CBT, and has been actually shown to be better than even a CBT in person. So very robust evidence for the CBT. So I think in summary, obstructive sleep apnea and cardiovascular effect, we have known about hypertension, pulmonary hypertension, heart failure, coronary artery disease, arrhythmias, diabetes mellitus, and cerebrovascular diseases. Um, Again, sleep well and live well. I always say that the sleep apnea is a heart disease and should be treated that way. PEP therapy is useful. At least it will reduce arrhythmias, improve heart failure, improve blood pressure. We still do not have a robust evidence that it will improve the mortality, but I think we are pretty close. PEP therapy definitely improves the sleepiness and the possibly road traffic accidents. This is again based on the compliance data. Person needs to have at least 4 hours or longer use for more than 70% of the time. And insomnia is a very, very common sleep disorder. Pharmacotherapy is indicated only for a short time. Otherwise, the sleep hygiene and the CBT are the primary treatment for insomnia. With that, I will say happy to answer any question. Thank you for this opportunity, Dr. Jacob, Dr. Fini, and Balamukesh. Thank you again and again.
A part of screening, like at some point of time we do blood sugar or lipid profile at some age. It varies from countries to country. So do you think apnea test needs to be part of a routine checkup at some point of time in those, or you would say that only in those with high risk you should do it? What do you think?
I think that currently we do not have a recommendation for the routine screening for the apnea, except in United States. At least the law is different in different states. But for example, in New Jersey or New York, the heavy motor vehicle drivers, they all need to be screened for the sleep apnea, because if they are feeling sleepy, they will create a disaster. Every other state does not have that law. For example, in Michigan, we have a Department of Motor Vehicle, DMV. So they will screen by the history and physical exam, but they will not subject every motor vehicle driver, the commercial drivers I'm not talking about the routine drivers. So the commercial drivers, they will screen by the history and physical exam. And as I mentioned, for example, their stop bank score is more than 3, then they will send it to the sleep specialist, and then the sleep specialist will screen them with a sleep study. Apart from the commercial drivers, I am not aware that any country does have a screening for the sleep apnea as a routine. But it has been also said on the other side, approximately 20% of a world population, probably more than a billion people on the earth, do have a sleep apnea. So especially after the age of 65, even if you just toss the coin, more than the half of the people will have a sleep apnea. So yes, for a high risk population, those who are obese, or those who are elder patient, or those who are feeling sleepy, certainly we recommend screening, but not for everybody as an adult population.
Thank you.
Dr. Dalal, can I ask you a question?
Absolutely, please.
So in the UK, we used to use the Epworth sleepiness score much more commonly than the stop band. But I understand that many pulmonologists don't like to use the ESS in India. What is the
No,
thinking about that? What do
we,
they have two different roles, these two scoring systems?
no. So that we do use upper sleepiness scale in the all the patient, but upper sleepiness scale is only for the sleepiness evaluation, whether the person is feeling sleepy or not. So in ESS, we have 8 different component. For example, the person is feeling sleepy during watching TV or not, and there is a scale from 0 to 3. 0 meaning by they don't feel sleepy at all, or like sometimes people doze off while they're watching TV or while they're reading the book. So what are the chances between 0 and 3? If a person always falls doze off, or always feeling sleepy while reading, will score 3 points. While they are not falling at asleep, or not nodding, or not dozing, they will point 0, or in between 0, 1, 2, and 3. So there were 8 different situations in the ESS. For example, watching TV, for example, reading the book, for example, lying down after the lunch without alcohol, for example, lying down after the dinner, while driving. So Apert sleepiness scale goes from 0 to 24, because 0 is the minimum score, 24 is the highest score, and the cutoff is 10. So if the people do have a ESS of more than 10, meaning by they are feeling so sleepy that will impair their day-to-day activities. So that is evaluating only one symptom, while stop bang is evaluating everything else. For example, snoring, for example, the tiredness, for example, their age, their BMI, their gender, their neck circumference, all this will be listed in a stop bang, while ESS is evaluating only one symptom. So we do use ESS in every patient, and not only that, we do use ESS periodically. So I do see the patient, the ESS is, for example, 15. I have a sleep study. It does show the severe sleep apnea. I do treat them on the PAP, and then the next time when they come, they will fill up the ESS again, and we will see whether there is an improvement in the ESS. So I have a people with a ESS for like 10 years. I'm following a patient every year for last 10 years. I have a 10 different ESS, and whenever the ESS is changing, we try to evaluate from that point.
Thank you. I don't see any other questions on the chat box. Dr. Balamukesh, can you see any questions?
No.
No. Yeah, we're also looking at Facebook Live and YouTube. I don't see any questions on that stream as well. So I think we must bring this to a conclusion, this talk. Thank you so much, Dalal, Dr. Dalal, for having opened our eyes to so many aspects of OSA and sleep medicine. Particularly the insomnia part of the talk was also extremely interesting to see, and how non-pharmacological methods need to be highlighted. Thank you very much for taking out your precious time this morning to be with us, and for us it's late in the evening. And thank you, Dr. Balamukesh, as well, for having agreed to moderate the session. We're very grateful to both of you, and we hope that we will meet again. And for all the audience, please continue to, you can watch this talk, it's on YouTube. You will be able to watch this, those of you who joined in late. And we wish you all a good evening, and have a good evening. Thank you so much for all of you who joined us.